Hello everyone and welcome back to my channel. This is Professor Asif Qureshi and you are watching Dr Asif Lectures. 10 Teachers Gynaecology से हम gyne के chapters कर रहे हैं and today the chapter that we are going to discuss is chapter number 16, which is Premalignant and Malignant Disorders of Lower Genital Tract. So we will particularly be focusing on the lower genital tract. So when we talk about lower genital tract, that basically means cervix and vagina. So these are the areas to focus, lower genital tract. And the learning objectives for today's lecture are to understand pathogenesis of the lower genital tract malignancy. Also, we will talk about pre-malignant conditions, which are not malignant, but they are known to have a potential to be converted into malignant disorder. यानी कुछ diseases ऐसी होती हैं which are per se they are non-malignant, but if the insult is not removed, is the risk factors are not removed, then they are transformed into malignant conditions. So pre-neoplastic situations इनको कहा जाता है, right? उनके बारे में भी पढ़ेंगे, and then obviously the malignant problems of lower genital tract. Then we also will aim to understand primary prevention of cervical cancer. मैंने आपको बताया कि lower genital tract में primarily cervix को हमें discuss करना है and vagina को discuss करना है. So cervical cancer comes in this domain, and you know very well that cervical cancers are actually very common. They are notoriously known to be caused by human papillomavirus, which is very, very prevalent across the world, and a lot of research has been done in this domain. Cervical screening has been proposed. Some vaccinations are also available, and this will be the topic. आज के chapter में ये भी हम discuss करेंगे. We also want to understand the diagnosis and the International Federation of Gyne and Ops, which is FIGO, staging and management of pre-malignant as well as malignant diseases of the lower genital tract, including cervix, vagina, and also vulva. So vulva is the whole part of the female perineum, from where the female genital tract basically begins, including the labia majora, minora, and then the vestibule leading to vagina. So this is all known as the lower female genital tract. Okay, so the introduction: cancer of the cervix is higher in higher income countries is relatively uncommon due to screening. Now, if you talk about advanced countries, the higher income countries, they have invested a lot in screening, early screening, pap smear, so they are very well caught. And once the cervical preneoplasia is caught, so see, the ultimate stage is cancer, right? But if there is a tool which can catch the disease at the preneoplastic stage or in a very, very early stage, then this conversion does not happen. So you basically stop the transformation of a preneoplasia to neoplasia. So this is where the developed countries have spent a lot of money, and they routinely have pap smear cervical screening in their routine checkups, right? That's why their incidence is now being controlled and actually going lower. Cancers of the vagina and vulva are far less common if you compare them with cervix. यानी हम इस lower genital tract में तीन चीजें discuss कर रहे होंगे. One will be cervix, one will be vagina, and one will be vulva. So vagina and vulvar carcinomas, they are pretty rare if you compare them with cervical cancer. Okay, so this is very common, very high. और इसका incidence is very, very high in lower income countries, perhaps because the screening strategies are not very effective. And this chapter covers pre-malignant as well as malignant diseases of the lower genital tract, covering these three domains. So let's first talk about the pre-malignant disorders of cervix. फिर हम cervix के cancer की भी बात करेंगे. But remember, this is not pre-malignant condition of cervix. This is very important to understand this, and also how to catch this, how to diagnose this. Because agar is stage पर somebody identifies, there is a female who is identified with pre-malignant cervical problem, this is where the intervention needs to be done so that this pre-malignant condition does not develop into cancer. Cervical screening has been shown to reduce both the incidence and number of death from the cervical cancer. So the screening has been very, very successful. Something like colorectal cancer की भी screening बहुत successful है. So some of the cancers जो बहुत common थे, prevalent थे दुनिया में, the screening tools have actually revolutionized their numbers. Breast cancer is one of them, and a simple breast self-examination. This is a very good screening tool. Similarly, is for occult blood in colorectal carcinoma suspects. Also, cervical screening is very, very successful in bringing the numbers of cervical cancer very, very low in developed countries. Okay. As so much so that it has been estimated that cervical screening prevents around 5,000 deaths per year in UK alone. So preventing 5,000 deaths from cancer, this is something, a very, very big number and a great success story. Now, cervical cancer is caused by, human papillomavirus is a very common association, and there are different categories of human papillomavirus. We divide them into high risk, low risk, moderately. So high risk human papillomavirus infection is very well associated with cervical cancers. HPV itself is a very small double-stranded DNA virus with more than 100 different subtypes, and these are classified into low risk or high risk depending on how much they can cause cancer. Obviously, high risk viruses can cause more cancer, and low risk types are 6 and 11, and they are usually associated with benign warts, benign condition. However, look at these numbers: 16, 18, 31, 33, 45. They are high risk, associated very strongly with cervical cancer. So remember these numbers, exam में ये बहुत पूछते हैं. And I think this is also making good sense because अगर आपको ये नहीं पता कि cervical cancer cause करने वाले viruses की subtypes कौन सी हैं, then you are missing big chunk, right? So HPV infection is spread during sexual intercourse. This is how it spreads. Infection is very common following the onset of sexual activity, and up to 80% of the adults show serological evidence of previous infection. Not necessarily everyone infected with HPV will develop cancer of cervix, not necessary. The virus itself is very, very prevalent. ये बिल्कुल ऐसे है जैसे there is another virus, the Epstein-Barr virus. The seropositivity for Epstein-Barr virus in general population is more than 90%, and it is spread very quickly, usually via saliva exchange during kiss in the teenagers or adolescents. But ये इसका मतलब नहीं है कि हर कोई जो EBV पॉजिटिव है उसको नेजोफेरेंजियल कार्सिनोमा हो ही जाएगा जो इस वायरस से होता है. इसी तरह HPV is also very, very prevalent. Okay, infection is usually transient and of no clinical sequence, but a minority of individuals actually develop persistent genital infection, and they develop to pre-malignant condition and malignant condition. So it's a very small number who actually go through this route of infection to pre-neoplasia to neoplasia. Smoking reduces the efficiency with which the virus is cleared by the immune system and increases the risk. So smoking is a strong risk factor along with this viral infection to cause cervical cancer. It's a no thing for cervical cancer. Women who are immunocompromised, for example, those with human immune deficiency virus or transplant recipients or on any immunosuppressive therapy, they are also at particular risk of pre-malignant and malignant cervical lesions. So anything which reduces or interferes with the immune system, even diabetes, or there are some conditions where you are on long-term immunosuppressive therapy, they make a person susceptible and prone to get cervical cancers. The tubular cervix is composed of stromal tissue covered by squamous epithelium. You know this from earlier lectures of 10 series. And then it changes, squamous, columnar, epithelium की बात कर चुके हैं. Now the endocervix contains many deep folds. These are called crypts. These are mucosal folds, and these are lined by columnar epithelium. The meeting of the two types of epithelium is called the squamo-columnar junction because columnar cells are then replaced by squamous cells, right? That transition point is known as the junction, and this is usually on the ectocervix, and you should also have this on the diagram. So this is the normal transition zone, but if you look here, this is that is a normal cervix also, but there is a little follicle visible, so that may be an indication of something. So this is actually not looking a good thing there. You see, this is absolutely normal. That's a normal transition zone. You just don't see any wrong thing here. So this is basically you are looking at the cervix with the scope. Okay, vagina में scope inserted here, and this is what you're looking at, right? All right. So the position of the squamo-columnar junction varies throughout the life. In children, it lies at the external cervical os. At puberty, it extends outward onto the ectocervix and cervix enlarges. And in adult life, it returns back to the external cervical os. And so these changes of the junction is very common according to the age. You should be aware of this. The so-called transformation zone is defined as the area between the original squamous-columnar junction and the current columnar junction, and where the epithelium changes from columnar to squamous over time. So जैसे जैसे area move करेगा, so for example, if the area is moving to this new point, this will all become columnar, and from here squamous will start. So ये junction ऊपर नीचे change होता रहता है, right? And this is the area which is susceptible to formation of premalignancy and malignancy. So you have to understand this, right? So for example, if these are columnar cells, right, and then from here squamous cell starts, and then this area changes. So for example, इस वक्त ये है squamo columnar junction, right? लेकिन अगर squamo columnar junction change होता है, shift होके इस जगह पे आ जाता है, तो what will happen? यहाँ वाले सारे cells जो हैं, there will be metaplasia, they will become columnar, and now from here squamous cells will start. So this is the new squamous columnar junction. Now अब ये जो area है जो change हो रहा है, this is called the transition zone, and this is where the malignancy may develop in future, क्योंकि cells का turnover हो रहा है ना, यहाँ पे metaplasia बहुत ज़्यादा हो रहा है. When human papilloma virus infection persists in certain individual, it triggers the oncogenic process in the transition zone, and this is where the immaturity starts, and the initial most phases are called cervical intraepithelial neoplasia. This is an intraepithelial condition, यानी epithelial cells के अंदर की condition है, and the cancer is diagnosed when the process breaks the basement membrane. So अगर cells neoplastic features आना शुरू हो जाए और basement membrane एक दफा जब breach हो जाती, then it becomes a true cancer. लेकिन जब तक सिर्फ neoplastic changes हैं contained within the cells, this is called intraepithelial. So cervical intraepithelial neoplasia. It can be low grade CIN1 or high grade up to CIN3, depending upon the abnormal cells are seen in the bottom third or the top third. यानी कितनी epithelium involved है उस हिसाब से. Obviously, if it is a high grade cervical intraepithelial neoplasia, the chances of this becoming a cancer are very, very high. Cervical intraepithelial neoplasia lower grade, the chances of this becoming to cancer are lower compared to what a patient with CIN3 would have, right? तो ये बेसिक कॉन्सेप्ट है. ट्रांजिशन जोन का कॉन्सेप्ट यार बड़ा इंपॉर्टेंट है, ये याद रखनी है आपने बात. Now, natural history of CIN, regression and progression of CIN may occur. This is an important point. In a normal life cycle of a female, this may happen. A spontaneous regression or lower grade disease is not uncommon. अक्सर फीमेल में होके रिवर्स भी हो रहा होता, पता भी नहीं चल रहा होता, because not everyone has pap smear. This is an argument for observational follow-up in the patient. High grade disease is less likely to regress if it is high grade progressing to cancer. ये बात हमने पहले भी की, right? There is a convincing link between CIN and the cancer of cervix, as nearly as all microscopic cancers of the cervix coexist with CIN. So once there is CIN, there are microscopic cancers. If it is very early stage, such as CIN1 or maybe earlier than that, there may be a reversal for some time, the patient becoming normal. But if it is CIN2 or 3, it may progress to cancer. How do you identify this? Cervical cytology. You take cells exfoliated from the cervix, kind of the screening जैसे करते हैं pap smear में. You put them onto a slide, you fix them, and then you see them in the microscope. However, the technique has now been modified and we do a lot of liquid biopsy. इसका setup थोड़ा सा different होता है, but basic idea वही है यार, cervix से आपने cells निकाल के microscope में check करने. That's what it is, right? You spin them down, you take the cells, you observe the cells. For more than 95% of the women, cervical cytology is normal and normal squamous cells are seen, such as these cells. These are normal looking squamous cells, but obviously if there is some pathology, you would see some pathological features. So for example, here you see there's a big nucleus in there, the cell sizes are different. So if this is a normal cell, look at these cells, their shapes are different, heteroplasia is present there, nuclear size is there, you may be able to see some mitotic figure. So signs and symptoms of some abnormal cellular activity, and this is what see in the liquid biopsy or the pap smear. तो ये आपको पता होना चाहिए, right? Severe dyskaryosis, यानी cells are changing in their characteristics and in their morphology. There is some correlation between the grade of cytological abnormality and the extent of CIN found in the cervix, but this is not reliable because ये जो cell chunk आप ले रहे हो, you're taking those cells from a small portion, you don't have the full picture, so you can actually not comment on the whole picture कि कितना basement membrane invade किया है, what are the extent and spread of these cells. but you have an idea that there's something wrong going on, and then you proceed further with further investigative tests. The sensitivity of single cervical smear for very high grade CIN detection is between 40 to 70%. It's not too bad. However, but you are missing a few percentage. I mean, you are missing like 50% of the patients anyway. So it is sensitive, but not too specific perhaps. However, there is a slow progression for most women with CIN to cancer. If a lesion is missed, then this would be picked up on a subsequent. So keep on repeating the pap smear or the liquid biopsy. There are chances that even if you miss on the first occasion, you may be able to pick it up in the next one. But consistency is the key. Okay, you have to perform the pap smear as per the recommended guidelines. Now, what is the role of HPV? We talked about it. It increases, the cellular characteristics change karta hai towards neoplasia in the transition zone. High risk HPV, you should remember the numbers. Testing improves the sensitivity, so you test for these viruses. PCR, for example, to check if they are present. Its value lies in extremely high negative predictive value. This is very good. So I hope you have the concept of positive predictive value and negative predictive value. If something negative, how sure are you that this is negative? If something positive, how sure are you that this is really positive? The majority of women, around 95%, have normal cervical cytology and they are pleased on routine recall. So just follow up. Women with high grade cytology are referred for colposcopic assessment. So you put the scope in and you see, and maybe you biopsy. Women with minor cytological abnormalities undergo reflex testing like HPV. So it really depends what you see on the pap smear, and from there you decide if you have to only do follow-up or HPV testing or colposcopy, for example. Since 1988, the UK has offered population-based cervical screening. It's a great step. Women aged 25 to 64 are invited every 3 to 5 years to take part in the screening program. Invitations for cervical screening and handling and the results are coordinated by NHSCCP, and they report the statistics. This screening program has been doing fantastically well. The main burden of cervical cancer is in low-income countries, and we do lie in those low-income or middle-income countries, Pakistan, India, Bangladesh, Sri Lanka, where it is common killer of women, so very common killer. So perhaps such screening programs are required much more in there. Colposcopy is the examination of the magnified cervix using light source. So you magnify, you see it. It is also for diagnosis and treatment. So it has diagnostic value as well as therapeutic value. Obviously, the woman undresses, places her legs in the semi-lithotomy position. A speculum is placed in the vagina, and cervix is examined under light source and magnification. So that's how you start. So this is the device that you use, right? So you basically illuminate and slightly magnify to see how the epithelial transitional zone is looking. Okay, the application of acetic acid in iodine solution highlights the abnormal areas of the cervix. Acetic acid causes nucleoproteins within the cells to coagulate temporarily, therefore areas of increased cell turnover, and obviously cell turnover आप expect करोगे अगर CIN मौजूद होगा तो start appearing white, right? So you see there, cervix with the, so आपने acetic acid जैसे ही यहाँ पे inject किया है, so imagine yourself, you're doing colposcopy and you inject acetic acid, you see these areas, with your naked eye you are able to tell there is something wrong going on in there. Cells हैं जो proliferate कर रहे हैं बहुत तेजी से, so maybe there is CIN. Now areas of CIN lack intracytoplasmic glycogen and fail to stain brown when iodine is applied. So this is another thing कि brown आपको shade नहीं मिलेगा, right? You see all these cells, they are devoid of glycogen in particular and other metabolites as well. All right. So these are the things you must know. If CIN is present, colposcopist जो कर रहा है colposcopy determines whether the appearance are low or high grade, if it's a small area of white plaque or it's a big area, so then they decide what to do next, right? The later can be treated in the clinic on the same visit, और अगर बहुत लो ग्रेड था तो you may then ask the person to come back in some time. A biopsy is usually very helpful to 100%ly know what is going on, and this is actually gold standard. So you examine under the microscope, and for sure you decide what should be the treatment standards, right? So this was all super important discussion, guys. ये सारा बहुत important है, एग्जाम के हवाले से बहुत ज़्यादा पूछा जाता है. So if someone identifies this pre-malignant condition, which is CIN, cervical intra-epithelial neoplasia, it is very effectively, it can be eradicated, ensuring that the post-treatment cytology is negative. You eradicate and you do the cytology again post-treatment to see if it is gone. High-grade cervical intraepithelial neoplasia requires treatment, usually with excision or ablation. Low-grade CIN regresses spontaneously in 60%, but you don't wait for them to regress low-grade. I would say just interfere, right? And do the treatment proactively. In the UK, the favored method of treatment for high-grade CIN is a loop diathermy. Under local anesthesia, you can do that, but some people may need general anesthesia. I'm not too much concerned to teach you how this diathermy is performed, but you basically ablate and you burn the cells which are going crazy. So CIN can develop within crypts of the epithelium as well. Therefore, excisional technique needs to be at least 7 millimeter deep so that you make sure that you are removing the majority of the chunk where CIN is possible. The procedure takes about 15 minutes under local anesthesia. It's a very quick procedure. The advantage of this excisional technique that it is clinically very effective. You do it on the same visit. You can do that. You see on the colposcopy, you see this area, you ablate that area by diathermy. You can do it right there and then. This is very easy to do, particularly if you are suspecting low grade of CIN. The disadvantages relate to its potential impact on the obstetric outcome. Small excisional treatments are unlikely to have obstetric. Usually इसके इतने major obstetric problems होते नहीं हैं unless you are a very unexperienced type of person and doing some bizarre things there, right? This concern relates to young women who obviously want some experienced hands to treat their stuff, right? But anyways, simple stuff, you do diathermy. Other options involved, which have been also suggested for treatment of CIN, they include cold coagulation, cone biopsy, you remove a cone from the cervix, but I think now people are more referring to diathermy. They're doing diathermy more as compared to the other old procedures. Patients who have received treatment for CIN undergo a test of cure 6 months later. This includes a high-risk HPV test. Again, you do the pap smear and cytology. If negative, the woman is returned to routine recall. She's fine. That is the cervical screening 3 years. She's back to normal pattern. लेकिन अगर 6 महीने पे चीजें पॉजिटिव आती हैं, आपने ट्रीटमेंट किया, 6 महीने में फिर पॉजिटिव, repeat colposcopy, see again, do the treatment again. So that's the kind of thing. HPV vaccination के हवाले से कुछ बातें आपको क्लियर होनी चाहिए. This is very emerging field and new vaccines are becoming available day by day. HPV vaccines have been shown to be safe and effective at preventing persistent high-risk HPV infection. This is one of the vaccination which has been very important and pivotal, and I would say वेरी वेरी इफेक्टिव इन कैंसर डोमेन. तो अगर आप कैंसर्स की बात करें तो बहुत ज़्यादा कैंसर्स ऐसे नहीं मिलेंगे आपको जिनमें वैक्सीनेशंस ने काम किया हो, बट दिस वन इज़ एन एक्सेप्शन आई वुड से, बिकॉज उसका रीज़न परहैप्स ये है कि ये जो कैंसर है, दिस इज़ वेरी स्ट्रांगली एसोसिएटेड विद द वायरस. व्हेन माइक्रोबायोलॉजी कम्स इन देयर, वैक्सीन्स आर प्रोड्यूस्ड. सो वेरी वेरी इफेक्टिव वैक्सीन, ओके, हाई रिस्क वायरसेस को टारगेट करती है. The bivalent vaccine, which prevents persistent infection of HPV type 16 and 18, these are very high risk. मैंने ऊपर बताए थे इनके नाम. And together they are responsible for more than 70% of the cases, I would say. तो अगर ये दो viruses control कर लिए तो आप बहुत सारा cancer control कर रहे हैं. In fact, counting for about 70% of the cases, right? In 2011, the bivalent vaccine was replaced by the quadrivalent vaccine, which gives additional safety against 6 and 11 serotypes as well. So it's covering like up to 85% of the cases. So very effective care. Now polyvalents are also available. Key learning points up till now: the cervical cancer is now considered as a preventable disease. It's a cancer which you can prevent. The key here is that you identify things at this stage. Once this is identified, you treat there right and then it is not converted into cancer. That's the key. Okay. And how do you do that? By doing screening such as pap smear or cytology. Now, prophylactic HPV vaccination can be used, and it has been very, very effective and useful. Regular screening is the key. Women who are treated for high-grade CIN are at increased risk of cervical cancer, because जितना देखो आप CIN निकाल लो ना, cervix से आपने कॉटरी कर लिया, डायथर्मी करके निकाल लिया, फिर भी यार कुछ सेल्स पॉसिबल है ना अंदर रह गए हों, वो कैंसर में ट्रांसफॉर्म भी हों और स्प्रेड भी हो जाए. सो पेशेंट्स हु हैव लो CIN सच एज CIN1, उनका ट्रीटमेंट करके 6 महीने का फॉलोअप एंड देन रूटीन फॉलोअप. लेकिन CIN3 वालों को, फॉर एग्जांपल दीज आर हाई ग्रेड, इनका फॉलोअप आपको ज्यादा रखना पड़ेगा. ओके. तो this was the discussion which was particularly focused on CIN. If you note, हमने CIN1 की बात की, 2 की बात की, 3 की बात की. How do you treat? How do you follow up? Now let's have some specific discussion upon the malignant disorder. Now the scenario is कि अब cervix का कैंसर हो ही गया. Now what to do? These patients have variable clinical presentation. ये डिपेंड करता है कि कैंसर कितना एडवांस स्टेज पर है और कितना लार्जर मॉर्फोलॉजी है उसकी. सो मैनी पेशेंट्स विद स्मॉल वॉल्यूम ऑफ डिजीज, दे आर पिक्ड अप एक्चुअली इंसिडेंटली, यानी कोई खास क्लिनिकल प्रेजेंटेशन उसकी होती भी नहीं है, एंड इट इज जस्ट इंसिडेंटल. सो रूटीन अगर पैप्समियर हो रहा है, उसमें किसी को डाउट हुआ कोल्पोस्कोपी की, तो वहां पता लगता है कि अच्छा जी ये तो कैंसर है, बायोप्सी पर ये पता लगा. मोस्ट सर्वाइकल कैंसर, हाउएवर, दे आर वेरी फ्राइबल, दे आर वैस्कुलर masses, so blurry masses. Female can complain. They can be visible on the cervix on examination by the physician. The patient presents with abnormal bleeding. So this is a very common and routine complaint. Post-coital bleeding, yani bleeding after sex. So whenever there is any activity at the cervical area, there is bleeding, which can be prolonged. It can be intermenstrual bleeding, yani the dates के बीच में bleeding हो रही है, or sometimes post-menopause. Post-menopausal bleeding is always a red flag. Once it's a menopause, then why is the bleeding happening? So these are the common presentations. Any women with these symptoms should therefore undergo a pelvic examination thoroughly, and that must include visualization of cervix. Doctor must see the cervix. In advanced stages such as 3 and 4, patients may experience a number of distressing symptoms such as pain, anemia because of a lot of blood loss, renal failure because the cervical cancer mass can actually block the ureter, so that can lead to renal failure. Now that would be a very, very interesting and important presentation in your examination. So if you're solving a clinical vignette and they start with renal failure and land up onto cervical cancer, you should know the relation. Cervical mass can actually obliterate and obstruct the ureters. Okay, sometimes there can be incontinence because of vesicovaginal fistula formation. So a lot of local effects and systemic effects as the disease progress. But any female complaining with bleeding post-coital, abnormal bleeding during the dates, intermenstrual or postmenopausal, they must be investigated appropriately, right? So that's, it's a bad-looking cervical cancer. A pelvic and speculum examination, they usually clinches the diagnosis, because if you have a look, you cannot miss cervical cancer presentation, right? Along with the symptoms, you reach to a diagnosis. And biopsy is the gold standard to confirm that this is cervical cancer. Very occasionally, the diagnosis can be missed. This is very uncommon that you miss a diagnosis after the presentation and the examination and the laboratory investigation and the biopsy. You usually pick it up, right? You know that majority of these cancers are squamous cell carcinoma because of the original epithelium which is there, and they are adenocarcinomas, which is the remainder. So most of them is 70% squamous cell carcinoma of cervix. In higher income countries with screening programs, there has been a relatively fall in the number of squamous and a relatively rise in the number of adenos. But anyways, still today, this has been the statistics. Most common is squamous cell carcinoma. In the UK, 30% of tumors are adenocarcinomas and less likely to be picked up on cervical screening, because these are the squamous cells that you actually look at the pap smear, right? Precursors of adenocarcinoma, known as cervical glandular intraepithelial neoplasia. This is something important, can also be detected at colposcopy, although lesions reside within the endocervical canal. So this is coming up. CIN, cervical intraepithelial neoplasia, to squamous cell neoplasia of cervix. This sequence is well studied, well known, well documented, well treated, but this glandular component is coming up now, tumor. Now the percentage of these glandular adenocarcinoma is raising up. So you need to keep that in mind. Cervical tumors are locally infiltrative in the pelvic area, but they also spread via lymphatics. मैंने आपको local infiltration के तो effects बताए ना कि ureter may be blocked and things like that, but lymphatic से भी इनका spread होता है. The tumor can grow through cervix, reach the parametria in the anatomical area lateral to the cervix, including an encroaching bladder, vagina. Metastasis can happen through lymphatics, perhaps periodic lymph nodes going to liver and lungs. So very important paragraph, ladies and gentlemen, for the pathophysiology of cervical cancers. What investigations for staging, particularly assessing the stage of the disease? This is important because you need to treat it. You need to know how far the tumor has actually spread, and उसके लिए आपको obviously कोई ना कोई radiology करनी होगी ना, CT MRI type की चीज, right? Stages अभी बताता हूँ मैं. Patients are staged according to the FIGO system, that's the international classification system, and a biopsy is crucial to confirm the malignancy. So you do the biopsy and you do the radiology. So this combination then gives you perfect staging. And if you look at this table, here are different stages. So stage 1, for example, the tumor itself is confined to the cervix. It has not gone anywhere. इसकी फिर अपनी बहुत सारी classes हैं, 1As and 1Bs. 1A is the microscopic disease. Tiny whiny disease is small. Maximum horizontal dimension is not more than 7 millimeter, and depth of invasion no more than 5 millimeter. Confined to the cervix. Cervix से बाहर नहीं निकला मामला. Then 1A की भी divisions है, A1 and A2. अगर डिवीजन डेप्थ वाइज 3 मिलीमीटर है तो इट्स 1A1 एंड अदरवाइज 1A2 बट नॉट मोर देन 5. बीज में जब आ जाते हैं, सो द लीजन इज ऑब्वियसली ग्रेटर इन डायमेंशंस देन ग्रेड 1A, okay, but it is still no more than 4 centimeter in size. In 1B1 and B2 made is slightly more than 4 centimeters. So 1 is purely confined to cervix, and this is the most good one, I would say, to have. It's not good to have the cancer, but if somebody has it, the 5-year survival rate is very good with type 1. Not type 1, stage 1 disease. And how would you know the staging? Staging is based on biopsy. You do the biopsy, you confirm the disease, and you do the radiology, which is MRI in this case. स्टेज 4 दूसरा स्पेक्ट्रम है. स्टेज 4 की देखें आप, सबसे बुरी प्रोग्नोसिस है. 5-year सर्वाइवल इसका सिर्फ 10% है. स्टेज 4A में द ट्यूमर इन्वॉल्व्स द म्यूकोजा ऑफ द ब्लैडर, रेक्टम एंड देन डिस्टेंट ऑर्गन्स. सो नाउ थिंग्स हैव गॉन बियॉन्ड सर्विक्स. इट हैज इन्वॉल्व्ड अदर ऑर्गन सिस्टम्स. और उसके बीच में फिर स्टेज 2 and 3 हैं. देयर इज वन कैटेगरी 2A जिसमें सर्विक्स से नीचे वजाइना भी इन्वॉल्व है, एंड पैरामेट्रियम यानी सर्विक्स के आसपास जो layers हैं mucosal, वो भी mesenchymal layers, peritoneal layers, these are also affected. So parametrium is also affected, right? Then tumor 3 category, even lower third of vagina is involved, 3A, and then pelvic wall, other structure, ureteric obstruction. जितना ज़्यादा ट्यूमर फैलता जाएगा उतना स्टेज बढ़ता जाएगा. Stage 1 being the minimum, confined only to cervix. Stage 4 being the maximum, going to the distant organs. Okay, so ये staging की story है. Okay. Now, treatment of cervical cancer depends on the stage of the disease. Obviously, I mean, जितना severe stage होगा उतनी severe surgery होगी. Ideally, the cancer patient should be discussed with the context of the multidisciplinary team, because अगर stage 4 patient है, for example, आप देखें ना, इसमें rectum involve हो सकता है, इसमें liver involve हो सकता है. So you have to involve multiple teams, perhaps surgery, anesthesia team, maybe physicians. तो ये आपको पता होना चाहिए. If it is stage 1, for example, now this is stage 1, it's a small volume tumor because it is confined only to cervix. Small lesions must be removed with a clear margin. यानी सिर्फ ट्यूमर नहीं निकालना, आसपास का भी एरिया निकाल देना है ताकि एक ही दफा सारी जान छूट जाए, right? So that's for 1A. लेकिन जाहिर है अगर bigger stages हैं, stages 1B से stage 4 particularly है, then you need bigger surgery, because this is now you are dealing with bigger tumor size, right? So it is no more confined to a small area. Perhaps you have to do radical hysterectomy. You may be doing bilateral pelvic node dissection, because stage 4 में बहुत सारे, even stage 3 में बहुत सारे lymph nodes involve हो जाएंगे. So is getting bigger surgery if later stages are identified. Okay, so when the disease is beyond cervix, which is stage 2 to 4, the radiotherapy becomes the optimal treatment because now things have gone beyond border and beyond control. Now, जब हम ये बात करते हैं कि सर्जिकल डिसीजन लेना है पेशेंट्स के लिए जिनको ये ट्यूमर्स हैं, कोई भी ट्यूमर हो फॉर दैट मैटर, it depends upon a lot of different things. So, for example, if somebody has a stage 4 cervical cancer, surgery may not always be possible. I mean, you may still be doing surgery. You may still be doing even hysterectomy and big surgery, in block surgery, touching upon different organs in the pelvis. But remember that if it is already in the liver, if it is already in the lungs, I mean, what extent of surgery would you do? Now, you do palliative surgery, you do surgery which helps the obstructive local symptoms, but then you also do radio and chemo. So radio and chemo, you are then, hitting the person with radiation. So the tumor cells, wherever they are, lungs mein hai, liver mein hai, so they are hit. Sometimes also chemo. So decision of how much surgery to be done, when to do the surgery, it depends a lot upon the patient condition, the extent of the stage. Every tumor patient is a different patient, and you have to take personalized decisions for them. Okay. The standard surgical operation is a radical hysterectomy, but again, ye jab possible ho, right? This involves removal of the cervix and the upper third of the vagina and also the uterus and the paracervical tissue. So this is what we call radical hysterectomy. Not an easy procedure to have, ladies and gentlemen, but anyways, this is a treatment for cancer. Lymphedema is variable, and obviously for any tumor, when you remove a tumor, you have to take care of the lymphatics. Otherwise, edema and all these are the complications of surgeries. More, I will talk about them in Belly and Love lectures. So, up till now, we have been talking about pre-neoplastic conditions of cervix, which is CIN, and then neoplasia of cervix. The learning points up till now have been cervical cancer affects young women. That's a nightmare because they have yet not completed their family, and you are removing the uterus, so it's not a good news for them. Many cervical tumors are picked up when they are microscopic. That's the good news. Cone biopsy, radical trachelectomy, or bilateral pelvic lymphadenectomy, the different choices for surgery. The long-term cure rate of radical trachelectomy is well established in radical Wertham hysterectomy. So I would say have the basic concepts ready in your head, ladies and gentlemen. Radiotherapy is also offered to patients who have advanced disease, for example. So the aim of the radiotherapy is to deliver a lethal dose of radiation to tumor and minimize the damage, because अब वो इतना फैल गया है कि you need to then cater it. Treatment is overseen by a radiotherapist. This is where the multidisciplinary team's involvement become important. Treatment is delivered in two ways: external beam radiotherapy, which is also called talitherapy, and an internal radiotherapy, which is called brachytherapy. In external beam, which is the earlier, the source of radiation is from the machine called the linear accelerator, and radiation is delivered to pelvis, a distance from the patient. The dose, आपको ये याद रहते हैं, अच्छी बात है, नहीं भी याद रहते, that's fine. Brachytherapy is a radiotherapy technique where the radiation is delivered internally to the patient. The source of radiation is usually selenium, and patients generally have to undergo an examination under anesthesia to insert the rod into the uterus. So सोचें ना, अंदर ही radiation मिल रही है. So these are two different, both have their pros and cons, but they are both practiced. Okay, chemotherapy is also used. So cisplatin particularly. अगर tumor surgery wise treatable नहीं है, then you go for broader killing strategies, which is radiotherapy and chemotherapy. And palliation, when it is not possible to offer curative measures to the patient, you go for palliative measures. So the patient life quality improves a little bit and the symptoms are under control, right? So, for example, you give painkillers. Malignancy ka pain is a mess. Agar kahin koi obstruction hai, you put a catheter in. So, for example, urethra is obstructed, you put a catheter in. These sort of things where you are improvising the life, you are improving the patient's symptoms. This is what we call the palliative treatment. And this is reserved for the patients in whom surgery is not possible, chemo radio is not possible, but you still have to calm down and, simplify and facilitate the patient's problem. So palliation is that sort of the end of the treatment, right? Now, after cervix, let's talk about malignant problems of vagina. They are rare as compared to cervix, but anyways, they do exist. So as you can see, vaginal cancers are rare, accounting for only 1 to 2% of the total gynecological malignancies, and the majority of the tumors arise from the spread from the cervix and endometrium. So vagina में जो cancers दिखते हैं वो secondary spread वाले ज़्यादा हैं. Primary vaginal malignancies are rare. The peak incidence, अब हम primary cancers की बात कर रहे हैं, 60 to 70 years of age, and there is one which you must understand and remember, which actually appears in very young age, which is 8 years of life, and that is known as sarcoma botrytis. So if exam tells you there is a vascular mass coming out of vagina, 8-year-old female, that has to be sarcoma botrytis. Think about it. More than 60% of the primary vaginal tumor are HPV associated, again जैसे cervix में था, and the risk factors for the disease include previous malignant, pre-malignant disease of the cervix. तो जिनको सर्वाइकल डिसीज हुई है, इनमें चांसेस हैं कि वेजाइनल नियोप्लेजिया भी हो सकता है. एंड द टर्म जैसे हमने वहां CIN यूज किया था, यहाँ पे VAIN है, VA फॉर वेजाइना, C फॉर सर्विक्स, राइट, इंट्रा एपिथेलियल नियोप्लेजिया. Clinical presentation is again abnormal bleeding and blood-stained vaginal discharge. This is very common presentation. And advanced disease may present with hematuria, constipation because rectum is involved, pelvic pain and tenesmus. These are all the local aggressive tumor की वजह से जो signs and symptoms develop हो रहे हैं, right? Staging again uses the FIGO classification. ये भी बताता हूँ थोड़ी देर में. MRI scan of pelvis confirms the clinical finding, and a CT scan metastasis को check करने के लिए. So if you look at the table here, which tells you the staging, stage 1 being the best one, stage 4 being the worst one, जहाँ 5-year survival सिर्फ 0 to 20% है. Stage 1 में the tumor is confined to vagina. That's the rule. If you are talking about stage 1 of cervix, the tumor is confined to cervix. If you are talking about stage 1 of vagina, the tumor is confined to vagina. अगर सब वेजिनल टिश्यू में चला गया, थोड़ा सा बढ़ गया, स्टेज 2, पेल्विक वॉल में स्टेज 3, एंड ब्लैडर एंड सराउंडिंग ऑर्गन्स इन्वॉल्व हो गए स्टेज 4. You know that, right? Most vaginal cancers are treated by primary radiotherapy, although early stage tumors may be managed surgically. So surgery, radiology. Now, vulva की अगर हम बात करें ना, vulva is the part where you have labia majora, labia minora in the vestibule. So this is all skin extension. Squamous cells की हम बात करेंगे यहाँ पे. So 90% of them are squamous cell carcinoma because they are actually skin. Labia majora is the skin, right? So they are squamous cell carcinoma. But because this is skin, melanoma is also present. Basal cell carcinoma is also present. You know, there are some glands in the vulva, such as Bartholin gland. So because there are glands, adenocarcinoma is also possible. And see, you have to start making sense out of things. So वो जगह जहाँ जो एपिथेलियम है उसी तरह का ट्यूमर होगा, right? यहाँ glands भी हैं तो adenocarcinoma भी होगा. It is generally accepted that squamous cell carcinoma of vulva is a disease of two separate etiology: high risk HPV associated cancers, which are on the background of the intraepithelial neoplasia, often in younger women, and then there is a category which is non-HPV associated. So remember, this is in older women and associated with the pre-malignant vulval conditions such as lichen sclerosis. Important. So ये बहुत important lines थी यार. वो vulvar tumors जो young age में हो रहे हैं, they are usually associated with HPV, and then older age में non-HPV and associated with lichen sclerosis. Important stuff. Clinically, they may present as a lump or ulcer or itching or bleeding, and a combination of these. And there are some important features here which we will talk about in a minute, and these are all important conditions which can actually lead to development of vulvar cancer. So let's go through them. There is vulvar intraepithelial neoplasia. These are associated with HPV and they lead to tumor, obviously. And इनमें risk of malignancy कितना है? Not that high, about 10%, and it can increase if the person is immunocompromised. Okay, so surgical आप इसको remove कर देंगे. That's one category. In older patients, this is the category which is deriving from a pre-malignant condition which is called lichen sclerosis, and इसमें patient presents with itching, irritation, and you basically give steroids to remove because this lichen sclerosis is an inflammatory situation. You try to inhibit inflammation so that the conversion to cancer does not happen. Okay, there is also extra mammary paget disease which involve vulva, and here also you do surgical excision. So you should be aware of these three conditions which can lead to vulvar carcinoma. Okay, investigation. They say that they have to be dealt in the specialty gynecologic clinics, of course, and you do sometimes just by looking at it, but the gold standard for diagnosing any cancer is a biopsy. Unless you see that in the microscope, you cannot 100% confirm that this is a cancer. But if you look at the vulva, I mean, you do see there is something abnormal there, right? I would like to punch excise this and see what's going on. A biopsy is needed to confirm. That's the gold standard. Okay, you may have to do CT, MRI to do staging, and treatment is vulval excision. You cut the part, and again it depends कि कितना डीप ट्यूमर है. So for example, यहाँ इसकी भी staging दी हुई है. Stage 1 confined to vulva. You remember the general principles. And stage 4 would be well spread in rectum, in vagina, pelvic bone, and stage 2 and 3 in between them. You can go through the table, try to memorize it. Depending upon what is the size of the tumor, you decide if you have to do surgery or if you have to go for generalized radio and chemo. So surgical excision, radical excision, aiming to clear the surgical margins for at least 10 millimeters is standard of care. So remove the tumor and 10 millimeter margin. Margin less than 5 millimeter are associated with unacceptably high recurrence. So if you don't do this, अगर आप सिर्फ ट्यूमर निकाल देंगे, आसपास छोटे मोटे सेल रह जाते हैं रेजिडुअल ट्यूमर, तो उससे दोबारा ट्यूमर ग्रो हो जाता है. Try to remove a good chunk. 10 millimeter is the guideline. Okay, sometimes you have to do a combination of radiotherapy and chemotherapy. कैंसर ट्रीटमेंट के जनरल प्रिंसिपल है, जहां कैंसर है उसको काटो, रेडियोथेरेपी देनी पड़ती है, कीमोथेरेपी देनी पड़ती है. That's what it is. Sentinel lymph node biopsy and groin lymphadenectomy. What does that mean? Untreated groin lymph node metastases are invariably fatal, but it's not possible to predict whether groin nodes are involved using current radiological techniques. So you try to, stain a dye in the tumor, and then you have the draining lymph node. You check the draining lymph node. The first lymph node where you see the stain is the sentinel lymph node, and this is the concept aid. Okay, the standard approach until recently has been to carry out full inguinofemoral lymphadenectomy. सारे निकाल दो. That is to remove all the lymph nodes. But यार ये तो अच्छी बात नहीं है ना. So what you basically now do is look for sentinel lymph node and then define how to proceed with the removal of the lymph nodes. Lymph drainage for lateral vulvar tumor is to ipsilateral groin lymph node. यानी अगर right side का है तो right side की lymph node, right? ये आपको पता होना चाहिए. Groin lymphadenectomy is highly morbid procedure. It's not easy, leads to disease, associated with significant post-operative and long-term complications. So this is not a good thing कि आप बस groin area खोलें और सारे lymph node निकालें. Not a good idea. Since groin nodes metastasis affect 15% of the patient undergoing surgery of vulva cancer, many women are being exposed to unnecessary risk. It's an important consideration, right? So vulvar cancer में lymphadenectomy, lymph node निकालना बहुत सोच समझ के निकालना है. So sentinel lymph node biopsy is an attempt to address this issue. बजाय इसके कि आप सारे lymph node निकालें, बीमारियां हों, long term मसले मसाइल हों. Sentinel lymph node is the first node in the lymph node basin to receive the lymphatic drainage. The theory states that if the sentinel lymph node is negative, then the rest of the lymph nodes are fine. मैं ये पूरा आपको समझा देता हूँ इस तरह कि suppose ये vulval region है, ठीक है, और ये right side के groin region की हम बात कर रहे हैं. So that's the female in the lithotomy position, and this is the first lymph node, this is the second lymph node, this is the third lymph node, right? So what you do is यहाँ पे ट्यूमर है, ट्यूमर में आपने इंजेक्ट की डाई, अब वो ड्रेन करके यहाँ आएगी ना. अच्छा, डाई अगर यहाँ आएगी, अगर डाई फर्स्ट lymph node पे पहुंच रही है, तो what you do is you pinch that off, you see if the dye is there. अगर डाई यहाँ पर है तो इसका मतलब इस ट्यूमर ने इस lymph node तक ड्रेन किया. And all of this you are doing on the table, you are doing on the per-operative table. आप सर्जिकल रूम में ये काम कर रहे हैं, डाई डाल रहे हैं और देख रहे हैं. अच्छा, अगर फॉर एग्जाम्पल पहले लिम्फ नोड में जब आपने चेक किया देयर इज नो डाई, इफ देयर इज नो डाई इसका मतलब आगे वाले भी लिम्फ नोड्स में डाई नहीं जाएगी. सो इन लिम्फ नोड्स को खामखा में फजूल में निकालने का कोई फायदा नहीं है. तो सोचे पहले क्या करते थे, आंख बंद की, सारे ग्रोइन के लिम्फ नोड निकालो, बाद में मसले मसाइल. इससे ये मसला हल हो गया ना कि अगर पहला वाला नेगेटिव है देन डोंट गो फर्दर अवे. Small vulvar tumors less than 4 centimeter with greater than 1 millimeter depth of measure are injected with a radioactive nucleotide before the surgery, and then you see them during the surgery, और फिर आपको ये पता चल जाता है सारा कि कौन सा lymph node निकालना है कौन सा नहीं. Okay, so that's the concept, that's the idea. So that's right before the surgery, you give them the dye, or even intraoperatively you can give the dye, and then you see if a lymph node is involved or not. If the first one is not involved, do not remove the later lymph nodes. As simple as that. Sometimes you also do give radiotherapy if the disease is not curable, or sometimes you use radiotherapy as an adjuvant. यानी सर्जरी भी कर ली और साथ में रेडियो भी दे दी ताकि बेटर कंट्रोल करे. Sometimes you also do chemotherapy. ये तो जनरल प्रिंसिपल है कैंसर ट्रीटमेंट का. Cut the cancer, give radio, give chemo. That is it, right? Key learning points: cervical cancer disease commonly affecting women in lower income country. Population-based screening is available. Patients with abnormal bleeding must be investigated. Early stage malignant disease of the lower genital tract is treated by surgical excision. Fertility sparing treatment. Many females ask for this, particularly if they are young age. They would love to have families, obviously. Most lower genital tract tumors are radio sensitive, but surgery is preferred. Sometimes surgery is combined with radio. Okay, chemotherapy is used alongside as an adjuvant as well. So there are a few questions, I think. Let's करते हैं एक आध question. A 32-year-old woman is diagnosed with 3 centimeter stage 1B. 1 है तो it is confined to the cervix. She is devastated because she and her partner would like to start a family. ये अक्सर लोगों का ज़ाहिर कंसर्न होता है. एज देखें ना इसकी 32. What fertility sparing treatment would you do? Right, so you do cold knife cone biopsy, let's radical hysterectomy. I mean इसमें तो आप निकाल ही देंगे ना सब कुछ, तो ये तो clear cut obvious answer है, आपने नहीं करना. Radical radiotherapy with cisplatin. I mean obviously think about it, this is going to damage a lot of things. Radical trachelectomy with bilateral pelvic lymphadenopathy. If you recall my lecture above, here is the description. That's the correct answer, right? Okay, a 48-year-old woman now attends the gynae department with prolonged vaginal bleed. Her last cervical smear was 8 years ago. Speculum examination revealed suspicious looking cervix. So speculum किया, bleeding on contact है, it's not looking good, right? और आखिरी pap smear भी 8 साल पहले हुआ था. What is the most appropriate initial investigation? You definitely have to do biopsy. You have to do biopsy to identify what is going on wrong. I mean MRI भी करेंगे बाद में, अभी इसकी ज़रूरत नहीं है. Transabdominal ultrasound is not going to help you because you need to make a diagnosis right now. Okay, LADS and hysteroscopy, all you can have. I mean you can have these procedures, but the definitive diagnosis that will be given to you will be by biopsy, right? What else do we have? We have some long questions here. Mrs. S is an 88-year-old woman who presents to the gynecology unit with a vulval lump. So vulva make lump hai, right? Lower part, perineal, vulval area mein. It has been bleeding intermittently. It is very sore and she is finding it difficult even to sit down. She is frail, lives in sheltered accommodation. Aged female, vulvar lesion. What is the most likely diagnosis? It's a new vulvar lump. Has to be taken as a vulvar cancer until proven otherwise, please. Okay. What are the key points in the examination and investigation? आपको इसको पूरा examine तो करना ही है, but you also have to do the biopsy. That's the key point. Always do the biopsy. Maybe you also need to combine it with CT and MRI to do the staging. So that's what you have to do. So if you read B, it's always important to get a biopsy done and a CT scan done for seeing how much metastasis and stage karna hai, basically kaun sa stage hai, right? The next question it says is how would you manage her? Obviously surgery alongside radio alongside chemo is the management option. Okay, so that's all about this chapter, and soon we will start the next chapter. All the very best till I see you next.